Our next speaker is coming at us from Italy. It's Dr. Accarino, who's going to talk to us, are we using all the available proximal sealing surface during EVAR 3D evaluation of proximal seal zone evolution in the long run?
Thank you. A big thank you to Dr. Ramaiah to give me the opportunity to present our work. I have no disclosures. The sealing zone is defined as the aortic segment in which the endograft is totally opposed to the aortic wall, and it is influenced by patient and procedure-related factors, and we distinguish a target sealing zone and a real achieved sealing zone, which has roughly the shape of a truncated neck, of truncated cone. We care most about its lateral surface. In our ongoing study, we aim to assess differences between the expected and the achieved sealing zone and to investigate variations over time and how events interact with the aortic sealing zone. We selected 275 patients treated with the same endograft at our institution and followed them up with CT scans. In our preoperative measures, we take the infrarenal level area, the most distal point of guideline neck area, and the distance between these two planes, again, in center lumen line. For the postoperative measures, we take again the infrarenal level. This is to correct for graft misplacement, fabric starting point area, and most distal point of complete stent apposition area, and the distance between these three planes. This is to show you why we need one truncated cone for the preoperative assessment and maybe two if there's graft misplacement in the postoperative assessment. These are our patients' comorbidities and measures, and these are our patients' outcomes. We got 59 endoleaks, and on the right, the survival curve, and these are the Kaplan-Meier curves showing the distribution of the events in our patients. If we look at the target sealing zone, we see that patients that developed an endoleak later in the follow-up had already a lower target sealing zone. This is because of length, because there are no significant differences in areas of the proximal and distal part of the neck. As we look at the real achieved sealing zone, we see kind of a different picture, because as the sealing zone of patients that develop an endoleak is lower, it is for a combination of factors that are related to the area and also to the length. There's a clinical implication of poor values as patients with proximal sealing area shorter than 13 millimeters and a half showed an increased risk of type 1A endoleak as well as for a decreased surface. When we compare target and achieved sealing zone, we see that the achieved sealing zone is often lower, and this is not only because of length, which is the most important factor, but also because of area. So we're not using all the available sealing zone, and not because of graft misplacement. 65% of the endograft were perfectly placed, while another 20% lost for 1 millimeter. This relation is always is expected even if we delete patients with a misplaced endograft. Again, the endograft didn't reach the nominal area at the most distal point of stent apposition, so there should be enough room for it to dilate. The proximal sealing zone is, of course, evolving through time, with most of the changes happening between the first 1 to 3 years. Events, of course, interact with the evolution of the proximal sealing zone. You see the two curves go together until the 16th month where they split, and there's a difference, statistical significance between endoleaks and time. Type 2 endoleaks are responsible for sealing zone evolutions more than type 1A endoleaks, because when there's a type 1A endoleak, the sealing zone is 0 for definition, but type 2 endoleaks interact with the proximal sealing zone evolution. Why is this? It's not because of the infrarenal area that is increasing in both groups in a similar way, as is also being reported by many literature studies. This is the same for the most distal point of stent apposition. Of course, length is changing between groups, the group that developed endoleaks and not. Type 2 endoleak, again, is responsible for this variation. So what is the data telling us? Data is telling us that the target sealing zone is often different from the achieved sealing zone, that the first controlled CT scan may help us understand which patients have increased risk of type 1A endoleaks, and the proximal aortic sealing is evolving over time with most of the changes happening in the first few years, and type 2 endoleaks are able to decrease the proximal sealing zone. Clinical implication of this should be that patients with a shorter sealing zone may be followed up more closely, and that sealing zone should be treated as aortic shrinkage. I mean, if we do not see sealing zone increase in the follow-up CT scans, maybe our patients are at an increased risk of endoleak. Our study, however, is still ongoing because we don't have enough data, because there's a lot of anatomical variability between patients and it's difficult to obtain really robust statistics. Out there is well known that the aortic neck is evolving and that this correlates with endoleaks, and so it is in our study. Neck dilation may be tied to endograft model, as we saw with polymer technology. It's different, but we need to keep in mind that it affects also patients that undergo open repair. So maybe it is something that we just cannot avoid. In the future, with a larger database, we could be able to develop more personalized risk profiles and follow-ups protocol, which can be more efficient in managing the patients in the long run. And of course, data such as this could help develop the next generation of endograft. That's why we're looking for collaborators to give us patients' data and suggestions on methods and statistical analysis. Thank you for your attention.